Class 2 Division 1 Malocclusion by Batul Muhammad. List of content. In this presentation we will talking about definition of a Class 2 Division 1, etiological factor, and extra and intraoral clinical findings, diagnosis, treatment in primary dentition age, in mixed dentition age, and finally in adult. Definition of a Class 2 Division 1. In molar relation, the mesial-buccal cusp of upper 6 occluding anterior to the buccal groove of lower 6 with normal inclined or proclined maxillary central incisors, as you can see in this picture. Etiological factors, they classified into prenatal factors, natal factors, and postnatal factors. Prenatal factors, genetic and congenital factors. Studies done on parents and children show they have the same malocclusion, indicated that facial dimensions are principally determined by genes. Certain drugs, when administered during a pregnancy that have potentially produce abnormal development, such as teratogens. Irradiation therapy during fetal life can be a causative factor for Class 2 malocclusion. Intrauterine fetal posture, like hand placed across the face, have an effect on craniofacial growth, especially on the mandible. Natal factors. Improper forceps application during delivery can lead to condylar damage or fracture, thereby causing internal hemorrhage in joint area. The joint may later become ankylosed or fibrosed, leading to underdevelopment of mandible, and finally this will cause Class 2 malocclusion. Postnatal factors. Sleeping habits, for example stomach way. Traumatic injuries, direct or indirect trauma to the facial structure. Long-term irradiation therapy. Certain infectious condition, for example rheumatoid arthritis. Pernicious habits, like for example tongue sucking, tongue thrust, or lower lip biting. Anomalies of dentition, like malformed teeth, or big lateral or congenitally missing teeth, like missing lateral incisors. Clinical findings. Let's start with extraoral features. In a frontal view, face is usually oval, mesocephalic to dolichocephalic. Mesocephalic mean average, dolichocephalic mean long narrow face. Stretched upper lip due to proclined incisors, no lip seal, and posterior facial divergence. It means the line drawn from the forehead to the chin inclined posteriorly. Deep mentolabial sulcus, decreased nasolabial angle, convex facial profile. This means the angle that formed by the first line drawn from forehead to the soft tissue point A and pogonian to soft tissue point A will be acute angle. Thus will form convex facial profile. A decrease in lower facial height and hyperactive mentalis muscle. In intraoral features, Class 2 molar relationship, indicating distal relationship of mandible to maxilla, as we mentioned in the definition. Upper incisors are proclined, so there is an increasing in overjet. There is a deep bite, which may be traumatic in nature. An exaggerated curve of SB, and upper arch is usually narrow, V-shape, and palatal vault is usually deep but may be average. Diagnosis is depending on history, intra and extraoral examination, study model, orthodontic photographs, and radiograph like cephalometric or OPG. Treatment is classified according to the age of the patient in 3 categories. First of all, in a primary dentition age. Second, in mixed dentition age. Third, in adult. In a primary dentition age, it's just a preventive measure for the habits that may produce class 2 in the future. First of all, mouth breathing. The treatment of choice is habit-breaking appliance such as oral shield, an oral shield, as you can see in the picture. Abnormal tongue position or tongue thrust. The treatment of choice is tongue grip. If the habit is lower lip biting, there are many exercises are suggested. First of all, take a lower lip over the labial surface and try to exert backward pressure. Second, extending the lower lip over the upper lip massage exercise. Third, lip exercises may be holding a paper between the lips. All of the above exercises should be done for a minimum of 30 minutes in divided periods. Each period is 5 minutes, which would restrain and correct the abnormal muscular activity. Thumb sucking and finger sucking habits. No intervention is needed until deciduous teeth are erupted because they usually tend to stop by then. Giving dummies, which are less deleterious in nature, and adult approach by giving a mature talk. And also, reward system and reminder system are also suggested. The off-ending digits can be painted with a pungent substance. If all of the above fails, then treatment by habit-breaking appliances is the treatment of choice. The treatment options in mixed dentition period are, first of all, management of a class 2 malocclusion with maxillary prognathism with normal mandible by headgears. Also, the maxillary splint can be used. Management of mandibular deficiency. The primary goal is to enhance mandibular growth. The various functional appliances used for this purpose are activator and Frankel, herbist, and so on. Treatment options of a class 2 division 1 in adults are dentoalveolar approach. Dentoalveolar compensation for the skeletal defect through reduction of tooth material is the treatment of choice because the patient has surpassed the stage when growth could be harnessed to correct the skeletal malrelationships. Surgical approach for correction of maxillary prognathism like partial maxillary retropositioning. And finally, surgical approach for correction of mandibular retrognathism, intraoral bilateral sagittal split osteotomy. Thank you for your attention.